and the muscles producing by, right, these movements. And in the last, the clinical application. So let's begin with shoulder complex. Clear? So what do you understand by, or what is shoulder complex? The shoulder complex or shoulder girdle, the joints which are forming this girdle, just a minute. All right, the joints which are 4 in number of shoulder complex connect the bones of upper limb with the axial skeleton. The bones of upper limb with the axial skeleton. So let's enumerate how many joints are involved in the shoulder complex. The first and the very most is the sternoclavicular joint. The sternoclavicular joint is present between the clavicle, medial end of the clavicle, the manubrum sterni, and the first rib. The second is acromioclavicular joint. The acromioclavicular joint is present between the lateral end of the clavicle and the acromion process of the scapula. The third joint of the complex is glenohumeral joint. The glenohumeral joint is present between the head of the humerus, right, and the girdle, glenoid fossa of the scapula. And the fourth and the last most, which is not a true joint, it is a functional joint, which is scapulothoracic joint. The joint is present between the scapula, body of scapula, and the thoracic wall, posterior thoracic wall. Clear? So these articular structures of the shoulder complex are primarily designed for providing the mobility and allowing us to move and position the hand through a wide range of space, right? So there is an extensive of mobility at this shoulder girdle. So let's take individual joints. The very first is sternoclavicular joint. So let's see the sternoclavicular joint. Clear? All right. I hope you can see me here, right? Sternoclavicular joint. It is a saddle variety of joint. So first see that sternoclavicular joint is present between medial end of clavicle, right, the sternum, and the first rib. So it is a saddle variety of joint due to their shape of articular surfaces. It is a complex and a compound joint. So what do you understand by complex? Complex means the joint cavity of this joint is divided by a fibrocartilaginous disc. This disc divides the whole joint cavity into 2 compartments. One is the lateral compartment and one is the medial compartment. The lateral compartment, suppose I am telling this fibrocartilaginous rim disc is menisci, right? So the compartment, lateral compartment is present between a menisci and the sternal end, right? And the medial end of the clavicular. So this compartment name will be meniscoclavicular compartment. Clear? And medially, this compartment is known as meniscosternal compartment. So it is a complex joint. Now, what do you understand by compound joint? The compound joint means the joint is formed with more than 2 bones. So here the 3 bones are involved. Clear? The 3 bones, first is the clavicle, next is manubrum, right? Sternum, manubrum, sterni, and the third is the first rib. So it is a joint between 3 bones. So it is a compound joint. So it is a saddle variety of joint. It is complex, compound, and 3 bones are articulating. Clear? Now let's see the articular surfaces. So this articular, there are 3 articular surfaces, and the articular surfaces are saddle in shape. So let's first see the clavicle. Medial end of the clavicle is articulating. If you remember the demonstration of clavicle, you should have remembered that the clavicle above downwards is convex. Above downwards it is convex, and before backwards it is concave. Clear? And opposite to it, on the sternal end, right, on this manubrium sterni, above downwards it is concave, and before backwards it is convex. Clear? And there is a notch, another notch on the sternum for the first costal cartilage, right? So the articulating surfaces, one is the medial end of the clavicle and another by notch formed by manubrium of sternum and the first costal cartilage. Do remember, kids, here the articulating surfaces here are not lined by hyaline cartilage. It is lined by a fibrocartilage. Clear? It is lined by fibrocartilage. Next to the articulating surfaces, ligaments. So let's enumerate the ligament of sternoclavicular joint here. The first and very most is fibrous capsule. Next to is fibrous disc, sternoclavicular ligament, anterior sternoclavicular ligament, and posterior sternoclavicular ligament, interclavicular ligament, and costoclavicular ligament. Clear? Fibrous capsule. The fibrous capsule encircles the articular surfaces and attaches to the peripheral margins of the articular surfaces. Clear? The fibrous capsule here is thickened anteriorly and posteriorly. The fibrous capsule of this joint is thickened anteriorly and posteriorly, and the thickening and the support is provided by sternoclavicular ligament, anterior sternoclavicular ligament and posterior sternoclavicular ligament. Clear? So this is about the fibrous capsule. Now, next is fibrous disc, or we can call it fibrocartilaginous disc, or we can call it sternoclavicular disc, right? So it is a fibrocartilage, right? It attaches superiorly to the posterior superior part of clavicle, and inferiorly it attaches at the junction between the manubrium sterni and the clavicle. Is that clear? Right? Superiorly it attaches to the posterior superior part of the clavicle, and inferiorly it attaches to between the manubrium sterni and the first costal cartilage, right? And anteriorly and posteriorly this gets fused with the fibrous capsule. Now this is dividing the joint cavity, as I have already told you, into two compartments. One is meniscoclavicular compartment and the another is meniscosternal compartment. One is lateral compartment, meniscoclavicular is lateral compartment, and meniscosternal is medial compartment. Please do remember this, because when I'm going to tell you the movements, right, this space becomes very important. All right, so let's move forward. Why we need this disc here? This disc is of very much importance because it prevents the medial displacement of the clavicle. When one applies force at the shoulder joint, this prevents the medial displacement of the clavicle. Is that clear, everyone? Next, the sternoclavicular ligament, right? As I've told you that there are two ligaments coming from the sternal end of the clavicle, right, and going to the sternum. So it is sternoclavicular ligament, which is present anterior or posterior to the fibrous capsule, right? If you can appreciate the direction of the sternoclavicular ligament here, that they are going medially, right? They are going medially. The fibers are going medially, means they also prevent the medial displacement of the clavicle. Clear? Next is the interclavicular ligament. This is the interclavicular ligament. These interclavicular ligament on both the sides arises from the non-articular part of the medial end of clavicle. You understand? Non-articular part, right? The superior part of the clavicle is non-articular, means it doesn't take participation in sternocostal joint, right? So this superior part is non-articular, and from there this interclavicular ligament arises and stretches above this suprasternal notch. Above this suprasternal notch. And the last and the very most important is the costoclavicular ligament. The costoclavicular ligament is very important as it acts as a fulcrum. All the translatory or rotatory movements of the clavicle occurs at this fulcrum, right? The weight of the body, the weight of the upper limb being transmitted to the appendicular system by this costoclavicular ligament only, right? So this costoclavicular ligament acts as a fulcrum. Now it has two lamellas, anterior lamella and posterior lamella. The anterior lamella here, I hope you can appreciate the anterior lamella and the posterior lamella. The anterior lamella, if you see the direction of the anterior lamella, it is going above. It is directed above and laterally. Above and laterally and inserting, attaching to the inferior surface of clavicle. Attaching at the inferior surface of clavicle. If you see the direction of the posterior lamella, it is going upwards and medially towards the inferior surface of the clavicle, right? In the inferior surface of the clavicle, near the medial end, there is a fossa for the attachment of this costoclavicular ligament. In the last, I hope you can appreciate this red muscle here, which is subclavius muscle. This subclavius muscle is of very much important. Although we have not included in the ligament and the capsule, right? This is an accessory support. What happens? The subclavius muscle provides the stability to the clavicle. उसको steady position में maintain करती है in every movement, right? In every movement at the shoulder joint, the clavicle is moving, right? To prevent the displacement, this subclavius provides the steadiness to the clavicle. So it is of very much important. Now let's move to the blood supply and the nerve supply of this joint, right? This joint is supplied by an internal thoracic artery. I hope you can appreciate this internal thoracic artery here, which is a branch of subclavian artery, right? The another is suprascapular artery. The suprascapular artery also gives supply to this joint, right? The suprascapular artery, which is a branch of thyrocervical trunk. Now the nerve supply. The nerve, it gets its nerve supply, this joint gets its nerve supply majorly from the medial supraclavicular nerve and minorly from nerve to subclavius. Now, medial supraclavicular nerve, this nerve are the cutaneous nerves, which are present in the neck. They descend downwards over the clavicle, and they divide into the supraclavicular nerve, divide into three parts: medial supraclavicular, intermediate, and the latter goes towards the acromion process, right? So out of these three, the medial one supplies this joint, right? And the nerve to subclavius, as subclavius is present here only, so it also gets its nerve supply from nerve to subclavius. I hope you all remember the brachial plexus, from where the nerve to subclavius arises. Can anyone tell me from where the nerve to subclavius arises? From the brachial plexus, which part, which trunk? And that point is also of great significance. Can anyone tell me that point? It's Erb's point, right? From upper trunk. Now, all right. Now the movement at the sternoclavicular joint. These are the movement present at the sternoclavicular joint, right? Deepika ma'am, excuse me, Deepika ma'am.
Yes, Dr. Nishant.
Am I visible?
Yes, you are visible, and they all responded also on chat box.
Okay, ma'am. This one. All right. Ma'am, this clavicle is visible to you? Because
no.
Now?
Yes, now it is visible. Yes.
Huh?
Yes, now it is visible.
Actually, I'm not able to see myself. I know what happened here. All right. Just a minute, please, everyone. All right. Can you appreciate this clavicle here? right? This is the medial end. This is the lateral end, right? Let's see first the movement present at the medial end, right? There are three rotatory movements and there are three translatory movements. Three rotatory and three translatory movements. What are the three rotatory movements? The three rotatory movements at the sternocostal joint is elevation, depression, protraction, retraction, right? And anterior and posterior rotations, right? And there are three translatory movements, right? Three translatory movements. The three translatory means gliding movements. Translatory means gliding movements. And three rotatory. Please, dear students, right? Protraction here and retraction here means moving forward, anterior forward, right? Moving forward. It's not related with the scapula here. Please, I'm mentioning again, all the movements which I'm telling here, the rotatory and the translatory movement are in the respect with this sternocostal joint only, right? So first I'll take the translatory movements, means gliding movements. The sternocostal joint movements are less appreciable, right? In a subject or in a patient, these movements are less, there are no prominent movements which you can appreciate. So they are less appreciable. Clear? So the gliding movements here are less appreciable. If suppose this is sternum, right, and this is the medial end, right? If the medial end, if the sternocostal joint movement rotates upwards, there is an upward gliding, right? It is superior translatory movement. If it glides downwards, it is inferior translatory movement. If it medially glides, medial translatory. If it's laterally, slight movement is there, glides laterally, it is lateral movement, lateral translatory movement. Anterior posterior, it goes anteriorly, anterior gliding, posteriorly, posterior gliding. So these are the gliding movements which are appreciated very less in this sternocostal joint. Now what are the rotatory movements? Let's begin with rotatory. Let's enumerate the rotatory first: elevation, depression, protraction and retraction, anterior and posterior rotatory movements. First I'll begin with elevation and depression, right? So elevation and depression. In this movement, what happens? Um, Correct. In this, what happens? Elevation. Look, this is the sternocostal. This is the medial end. This one is the lateral end. As I have told you that at the sternocostal joint, the movements are not so prominent. So we take the movement reference point, the lateral end, right? The movements here are not prominent. So we are taking the reference point at is lateral end. So when the lateral end goes upwards, right? Like in shrugging, when we shrug our shoulders, right? So we are doing this shrugging, elevation. And from the shrugging, when we come down, it is depression. Shrugging is elevation. When we are coming down, it is depression. So in shrugging, what happens? There is an elevation of the lateral end. I'm again telling you, the movement is occurring here, but we are not able to appreciate it much. So we are taking the movement reference point as lateral end. So when the lateral end goes up, right, the medial end at the sternocostal joint goes down. Actual movement is occurring here, but more appreciable is at the lateral end. So when the lateral end goes up in elevation, the medial end goes down in meniscoclavicular compartment, in lateral compartment. Is that clear? In meniscoclavicular compartment means lateral compartment. In the depression, what happens? When it comes back to its neutral position, the lateral end come back to its neutral position. It is depression. It is depression. And in depression, what happens? The lateral end comes down, right? And the medial end at the sternocostal joint goes little upwards, glides upward. It is a translatory movement. It glides, the sternal end glides upward in meniscoclavicular compartment. Is that clear? Is that clear? In elevation, the lateral end goes up, the medial end goes down. In depression, the lateral end goes down and the medial end goes upwards. The shrugging is more prominent, 48 degrees, right? And depression is less. Now let's move to next movement, which is your protraction and retraction. In protraction and retraction, what is happening here? Again, this is the medial end and this is the lateral end, right? In protraction and retraction, the clavicle is moving forwards. The clavicle is moving forwards. Look, this is elevation, depression, protraction. My shoulders are coming forward. Put your one hand at the sternocostal end, sternocostal joint, and produce the protraction. When you will do the protraction, you will feel that the medial side, means sternocostal joint, is also coming forward. So in protraction, what happens? The whole clavicle with rotation gliding comes forward. Clear? Comes forward. So the lateral end, which is more prominent, right? Which is more prominent, also glides forward, also rotate forwards. Even the sternal end also glides forward, right? So in protraction, both the medial end and the lateral end moves forward. Is that clear? There is an explanation to this also. We will discuss later, right? In retraction again, the both sternal end, means medial end, and the clavicular end of the clavicle moves backward. Clear? Now, if you see the degree of movement, it is more prominent for the retraction. This is protraction. But when we go back to neutral position and behind to the neutral position, we are going more backwards. So the retraction is 30 degrees and protraction is only 15 to 20 degrees limited, right? So retraction is more prominent than protraction. Is that clear, everyone? Moving forwards is anterior and posterior rotation of the clavicle. All right. Now here what happens? Please try to abduct your full abduction. Please perform full abduction, right? When you do the full abduction, put your one hand at the sternocostal or over the clavicle. When you do the full head abduction, you will feel that the clavicle is moving backwards. Put your hand down and another hand on your clavicle and perform the overhead abduction. In this overhead abduction, you will feel that the clavicle is going backwards, means that the clavicle is rotating, right? The clavicle is rotating in longitudinal axis, right? Posterior tilting, posterior rotation, anterior rotation, means it is a spinning rotation of the clavicle, little bit at the articular disc and very much little bit at the manubrium, but more prominent on the clavicle. So it is a spinning rotation. But guys, do remember this, that posterior rotation is more prominent. So much so that the inferior surface of the clavicle faces forward in posterior rotation. Faces forward in posterior rotation. So when you do your overhead abduction, the clavicle moves posteriorly. There is a posterior rotation. Clear? There's nothing like anterior rotation. There's no anterior rotation. But from posterior rotation, when it comes to its neutral position, when the clavicle from posterior rotation moves to its anterior rotation, right? That is known as anterior rotation. I'm not going to say that it moves forward. No, no. From posterior rotation, when it comes back to its normal position, neutral position, then it is called anterior rotation. And that is very limited. The posterior rotation is more prominent, and anterior rotation is only of 10 degrees. Is only of 10 degrees. I hope you understood the three rotatory movements. The first was a elevation, depression, right? Protraction, retraction, right? And posterior rotation and anterior rotation. Three movements we did. Clear? Now, the clinical applied part. Here you can see the two diagrams description. This is your manubrium sterni. This is your first rib, and this one is your clavicle. When the clavicle, hope you can appreciate, this is the normal sound side, and this is abnormal here. The clavicle has shifted anteriorly. And if you appreciate this, this is the sound side, and opposite side, the clavicle has shifted backwards. So dislocation has been occurred here. But students, please do remember that at the sternoclavicular joint, the degenerative changes are very less. Why? Because it is lined by fibrocartilage, not by hyaline cartilage. And the second and the foremost thing, that dislocation, fracture of this joint is very less than 1%, right? It is less than 1%, even the subluxation. So only the 1% of the clinical scenarios you will be seeing, including the sternoclavicular joint, right? Let's see a case. Here you can see a girl with a prominent medial end of the clavicle. So it is an anterior dislocation, right? Anterior dislocation of sternoclavicular joint. The clavicle has moved forward. This is all about the sternoclavicular joint. I hope you understood. I know it is little much difficult, but please try to understand more, right? Now let's move to next joint, which is acromioclavicular joint. Acromioclavicular joint, where it is present. Here, between the lateral end of the clavicle and the acromion process of scapula. This is whole acromion process. This is coracoid process. First identify these things: medial end, lateral end. Acromion process, coracoid process, and the head of upper end of the humerus. So the acromioclavicular is present between the lateral end of the clavicle and between the acromion process. Right? Now, type of joint it is? It is a plain synovial joint. Right? It is a plain synovial joint. Now, what are the articular surfaces? As I told you, that there is an oval facet present at the acromion process of the scapula and on the lateral end of the scapula. Clear? So these are the articulating surface, and these articular surfaces are also lined by fibrocartilage. These are also lined by fibrocartilage. Now let's move to the ligaments, right? So how many ligaments are there? Fibrous, clear? The fibrous capsule, articular disc. Now what it also has an articular disc, means it is also a complex joint. It is a complex joint, clear? And superior and inferior acromioclavicular ligament and Coraco clavicular ligament. Now first see the fibrous capsule. Look, fibrous capsule also encloses this joint, right? And attaches to the peripheral margins of the articulating surfaces. Clear? This fibrous capsule gets thickened or gets thickened upper side, right? And gets support by a acromioclavicular ligament. Acromion by superior acromioclavicular ligament, right? By superior and inferior acromioclavicular ligament. If I come to the articular disc, the disc here is partial. It is not complete. It is partial, right? Not completed, not completely dividing the joint cavity into two. It is just half, right? The next, the foremost is Coraco clavicular ligament. The Coraco clavicular ligament is the toughened ligament here, right? And it has two parts. Coraco, this is coracoid process, and above it is a clavicle. So it is a Coraco clavicular ligament. The Coraco clavicular ligament is, this Coraco clavicular ligament suspends the scapula, the whole scapula, with the lateral third of the clavicle, and it forms a strong bond of union between them, right? And it has two parts. The two parts. One is the conoid part, means cone shape, and the another is trapezoid part. So if I talk about the conoid part is inverted cone, and its apex attaches to the root of coracoid process. I hope you can appreciate this superior angle, superior border of scapula, suprascapular notch, and above there is a root of coracoid process. So from the root of coracoid process, the apex attaches and goes above to the clavicle.
Students, we are having some network issue. We are trying to resolve it, so please wait for a while.
All right, everyone.
Yes, Dr. Nishant, you were audible to us.
Acromioclavicular joint. So I was on the Coraco clavicular ligament, right? So Coraco clavicular ligament has two parts, right? It has conoid part and a trapezoid part. The conoid is apex, it's cone shaped, and the trapezoid is quadrilateral in shape. This conoid part attaches inferiorly to the root of coracoid process and above to the inferior surface of the clavicle. This trapezoid attaches to the anterolateral surface of the coracoid process and it goes above and attaches to the trapezoid ridge. Clear? So this coracoclavicular ligament is very important because it transmits the weight of upper limb, right, to the medial two-third of the part of clavicle. And medial two-third में किसके पास? To the costoclavicular ligament. And from there, these two ligament transmits the upper limb weight to the axial skeleton. Clear? So these are the important joints of acromioclavicular ligament. Now the blood supply of acromioclavicular ligament. The blood supply of the acromioclavicular ligament, the first, can you see this joint here? Right? It's supplied by the supra's artery, by suprascapular artery, and by thoracoacromial artery. Clear? And the joint gets its nerve supply from suprascapular nerve and from lateral pectoral nerve, and also from lateral supraclavicular nerve. I hope you remember that I told you from the neck, the subcutaneous cutaneous supraclavicular is running down and divides into three branches, right? The one goes towards the medial side, one goes to the middle, and one goes to the lateral side. And this is the nerve supplying here is known as lateral supraclavicular nerve. Now let's see the movements. Movements at this joint. Again, at this joint, the movements are three: rotatory movements and three translatory movements. Three rotatory movements, right? And three translatory movements. Right. So this is your scapula. Clear? This is your scapula. And this is your acromion process. Clear? Suppose this is your clavicle. The clavicle is articulating the acromion process and forming a joint known as acromioclavicular joint. Right? The movements at this joint are translatory movements and your rotatory movement. So what are the translatory movements? If this clavicle and acromion process, right, this moves slightly anterior, right? There is a movement of clavicle, lateral end of the clavicle anteriorly, right? So it is anterior translatory, and posteriorly, so it is posterior translatory. If this lateral end of the clavicle moves up a little, it is known as superior translatory movements, means gliding movement, and the lateral end of the clavicle goes downwards, it is inferior translatory movement. Clear? If it goes medially, right, then it is medial. And if the clavicle lateral end goes laterally, it is lateral translatory movement. Now the major part is of rotatory movements, right? Here also for the rotatory movements, we take a reference point. Reference point is that where we can appreciate the movement more, right? So we take the reference point here, the glenoid cavity. Clear? All right. First, I'll tell you the plane of movement. The plane of movement is the plane in which all these movements, internal, external, interior, posterior, upward, and downward rotation, these movements are occurring in a plane of scapula. Now, what do you understand by plane of scapula? What is plane of scapula? These are all occurring, these all movements at the acromioclavicular joint are occurring in coronal plane, but not exactly in coronal plane. This is your coronal plane. It is occurring in oblique coronal plane. oblique coronal plane, right? So sagittal, right, and the coronal, which is dividing the body into anterior and the posterior, right? So it is not occurring in coronal, it is an oblique coronal plane. Why coronal plane? Please think properly. Think that your body is dividing in the middle. The scapula is deviated. This is your coronal plane, right? And the scapula is not present in your coronal plane. It is slightly 35 to 45 degrees, 30 to 45 degrees. It is deviated backwards. पीछे की तरफ है. Coronal plane से scapula पीछे की तरफ है, right? और अगर मैं ये बोल रही हूँ कि ये सारी movements, all the movements are occurring at the acromioclavicular joint in a plane of scapula. So the plane of scapula is not the coronal plane because the scapula itself has been deviated backwards 30 to 45 degrees. So uska oblique plane अलग हो गया, right? So we will say that all the movements occurring in an oblique coronal plane, and this oblique coronal plane, right, is deviated from the coronal plane by 30 to 45 degrees. So all the movement at acromioclavicular joint are occurring in a plane of scapula. I hope it is clear to you or everyone. Now let's see individually the rotations, right? So how many rotations we have here? Internal, external rotation, anterior and posterior rotation, and upward and downward rotation, right? Anterior and posterior tilting, we'll say tilting. While tilting, I'll tell you why I'm calling it tilting, right? So let's see first internal and external rotation. What is internal and external rotation? In all the rotations at the acromioclavicular joint, we will take the reference point, the glenoid cavity, glenoid fossa, right? Because the movement are much prominent here. To see the movement here, we are taking it as a reference point. Although the movement is occurring at the clavicular, right, at the acromioclavicular joint, but we will take this point as a reference, right? So this movement is occurring in a vertical axis, right? It is occurring in a vertical axis, clear, right? And now what happens in internal rotation and external rotation? This what happens when the acromioclavicular joint performs an internal rotation, right? The glenoid cavity faces anteromedially. आगे की तरफ जाती है. It faces anteromedially. Clear? When it is external rotation, the glenoid cavity faces posterolaterally. So when there is an internal rotation, the glenoid cavity faces anteriorly, anteromedially. And when there is a posterior rotation, the glenoid cavity faces posterolaterally. This is internal rotation and this is external rotation. Internal rotation and external rotation. Clear? Now, what do you understand by tilting? Tipping. Anterior tipping or tilting or posterior tipping. Now here, the reference point is acromion process. To avoid the confusion, I can take the glenoid fossa also, but this will create a problem, right? So I'm taking the acromion process. See the tip of acromion process. Here there is an attached article, acromioclavicular joint. So in this anterior tilting means there is no proper movement. There's only a small tilt, right? This is internal rotation. This is external rotation, where gliding this glenoid fossa is moving. In tilting, what happens? There is a slight rotation of the acromion process and the acromioclavicular joint slightly forwards. So when the acromion process forwards, it is anterior tilting. When it goes backwards, or posterior tilting. So we here see only the acromion process. If you see the glenoid fossa, there is no movement occurring here, right? So in the anterior tilting, this is going forwards. Acromion process. In the posterior tilting, the acromion process going forwards. So this is your internal rotation, external rotation, and this is your anterior tilting and posterior tilting. Clear? Now, what else we can see here? The acromion process is moving, right? With this, when I'm producing the anterior tilting, the inferior angle goes backwards. In the anterior tilting, when I'm doing the anterior tilting, the acromion process goes backwards and the inferior angle of the scapula goes backwards. In posterior tilting, The acromion process goes backward and the inferior angle of the scapula goes forward. Clear? So this is anterior tilting. There is only a certain small movement, that is tilt. आगे की तरफ गिर रहा है. Anterior tilting, and there's a posterior tilting. Let's see the third one. The third one is upward and downward rotation. Upward and downward rotation. Now upward and downward rotation test. In this we take the ref point, again the glenoid fossa. In this the glenoid fossa rotation acromioclavicular joint पे इधर movement हो रहा है, तो reference point क्या हुआ? Glenoid fossa goes upwards, right? And when it coming back to its neutral position, it is downward rotation, right? So the movement occurring at this joint, right? So when the movement occurs at this joint, the reference point glenoid fossa faces upwards, and here it goes downwards. So when this glenoid fossa comes upward in overhead abduction, so in overhead abduction, the glenoid fossa goes upwards, and when coming down, it is a downward rotation. So at the acromioclavicular joint, we read 3 rotations. One was internal rotation, external rotation, anterior tilting, posterior tilting, right? And this is upward rotation and downward rotation. I hope this is clear to everyone, right? There are 3 rotatory movements, internal and external rotation, where the glenoid cavity faces forwards and backwards. There is an tilting, anterior tilting and posterior tilting. In the anterior tilting, only the acromion process goes forwards and the inferior angle of scapula goes backwards. Posterior tilting, this goes back and this comes forward. And the third, there's upward and downward rotation where the glenoid fossa, the reference point, goes upwards and downwards. I hope this is clear to everyone. The clinical applied. Here you can appreciate that the Costoclavicular Ligament, Coraco clavicular ligament. Here the Coraco clavicular, from coracoid to the clavicular, both conoid and the trapezoid ligaments are broken, right? So there is a dislocation of the joint where the acromion process goes down and the clavicle lateral end comes up. So this is acromioclavicular dislocation. Now the third joint. The third is scapulothoracic joint. Means this is the body of scapula and this is the posterior wall of thorax, and it is forming a joint which is known as scapulothoracic joint. Look, this joint is not a true anatomic joint. It is only a functional joint. Means the movement are provided by this, but it is not a true joint. Why it is not a true joint? क्या नहीं है इसके पास? It doesn't have a fibrous, cartilaginous or any synovial tissue. No specific, typical characteristic feature of a joint it has. So it is not a true anatomic joint. It is a functional joint. Now, if it is a joint, it has an articular surfaces also. So what are the articular? It has an articulation of the scapula with the thoracic wall, with the thorax wall, posterior thorax wall, and it depends on the integrity of the anatomic acromioclavicular and the sternoclavicular joint. What does this mean? Means इस joint की integrity wholly and solely dependent on the 2 joints, acromioclavicular joint and sternoclavicular joint. If there is any deformity or any dislocation present at the acromioclavicular or sternoclavicular joint, then the scapulothoracic joint will get hampered. The movement at the scapulothoracic joint will get hampered, right? So any movement of the scapula on the thorax must result in the movement of either at the acromioclavicular joint and sternoclavicular joint. Means कि acromioclavicular और sternoclavicular joint की movement पर dependent होती है इसकी movement, right? And that's why it is called functional scapulothoracic joint, right? And it is a part of true closed chain with acromioclavicular and sternoclavicular joint. So let's see the movements. These are the scapular movements which are provided by scapulothoracic movement with the help of acromioclavicular joint and sternoclavicular joint. So first see the movements. The gliding movement, right, which is more important. The gliding here is elevation and depression. All right. What is elevation and depression? Here. All right, see, when there is a clavicle elevation, right? When there is a clavicle elevation, acromioclavicular joint also elevate, and due to this, the whole body of the scapula, means suppose this is thoracic wall, right? This is thoracic wall, and on the thoracic wall, the scapula glides above for the elevation. In shrugging, the scapula moves above. Scapula moves above against the posterior thoracic wall. So it is elevation. It is a gliding movement. And in retraction, the body of the scapula on the posterior thoracic wall comes downwards. So it is depression, right? So elevation and depression is a gliding movement. In protraction and retraction, against the posterior thoracic wall, the scapular body glides forward, right? It glides forward. So it is when there is a forward movement, it is called protraction. When it glides back to its neutral position, it is called retraction. So how many gliding movements are present at the scapulothoracic? Elevation, depression, protraction, and retraction, right? Now the rotatory movement. There are two rotatory movements here, present here. What are those? Forward and backward rotation. Forward and backward rotation. If I say about the forward and the backward rotation, right? So you can see when there is an overhead abduction and there is downward adduction, this goes upward rotation, upward rotation, downwards rotation, upward rotation. The whole thing is rotating, not gliding. Upward rotation, downward rotation, right? So let's see the movement, scapular movement, elevation and depression. Here I'm going to tell you the mechanism. Clear? The mechanism. How mechanism? The scapula is elevating, gliding above. So two joints are responsible for this movement: acromioclavicular joint and sternoclavicular joint. Acromioclavicular joint and sternoclavicular joint. Why I'm telling you this? Why scapula is moving above? I'm telling you again and again. Scapula की खुद की movements नहीं है. The movements are occurring due to the movement present at the acromioclavicular joint and sternoclavicular joint. So how this whole body of scapula elevating and shrugging? So the mechanism here is, the elevation of scapula, that is upward gliding movement of the scapulothoracic joint produced by trapezius. Trapezius is pulling and the levator scapulae, right? Mechanism kya hai? There is an upward rotation of the clavicle at acromioclavicular joint. Upward rotation, right? And what is happening at the sternoclavicular joint, that medial end of the clavicle glides downwards and the lateral end of the clavicle is going upwards, right? In the meniscoclavicular compartment. So because the rotation and the movement is happening at the acromioclavicular joint and sternoclavicular joint, the elevation of the scapula is appearing. Clear? Mechanism kya hai elevation ka? Upward rotation of the clavicle at the acromioclavicular joint. Lateral end is moving above, right? The whole acromioclavicular joint is moving upward, right? And medial end of the clavicle, that is at the sternocostal joint, right? It is gliding downwards, and this produces the elevation, means shrugging. Depression. In the depression, the movement is just opposite, and it is majorly produced by the serratus anterior and pectoralis minor. The mechanism is same. At the acromioclavicular joint, the lateral end of the clavicle is downward rotated, and the medial end of the clavicle glides, right? It glides upwards in meniscoclavicular compartment. So this is elevation and depression. Now what happens in protraction? In protraction, the scapula is going forward. In protraction, the scapula is moving forward, right? And retraction, the whole scapula is moving backwards, means gliding over the posterior thoracic wall. The protraction is produced by the serratus anterior pectoralis major, and the minor muscle, right? For the protraction, the mechanism is the lateral end of the clavicle with acromion process advances forward, means internal rotation is there. Means internal rotation is there. This is scapula. Here is clavicle, right? This is acromioclavicular joint, right? So there is an internal rotation. Internal rotation. So this movement is happening. The glenoid fossa is going anterior and medially, right? So at the lateral end, what is happening? Acromioclavicular joint moving forward. Internal rotation is there. Clear? And the sternocostal joint also. The sternocostal joint is also moving forwards, right? So in protraction, there is forward movement, sternocostal joint. There is forward movement, acromioclavicular joint, and even the body of the scapula moves forward, right? Glides forward on your posterior thoracic wall. Clear? In retraction, there is an opposite movement, right? What movement? At the sternocostal joint, it retracts backwards, right? In menisco-sternal compartment. एलिवेशन और डिप्रेशन में कहाँ हो रहा था? मेनिस्को क्लैविकुलर में. और प्रोट्रैक्शन रिट्रैक्शन कहाँ हो रहा है? मेनिस्को sternal compartment. This also glides back. Acromioclavicular also goes back, and the body of the scapula also glides backward to its neutral position. On the posterior thoracic wall. It glides backward. ये क्या है बेटा? Gliding movements है. Elevation, depression, and protraction, retraction are the gliding movements. Clear? Let's see another movement here. Forward and backward rotation. What are forward and backward rotation? Forward rotation is expressed by the movement of inferior angle of scapula, right? It is more prominent when we see the inferior angle of the scapula, produced by the upper and the lower part of trapezius and 5 digitation of serratus anterior. Now, in this mechanism, forward rotation, what happens? In this, what happened, right? In this, what happened, right? Rotation means forward rotation and upward rotation. Here, the glenoid fossa faces upward, right? Prominent, the inferior angle of the scapula also moves upward. So this is happening in overhead abduction, right? The gravity and the inferior angle moves upward. This is forward rotation. When it comes back to its neutral position, inferior angle and the glenoid fossa, it is known as backward rotation, right? So these are the forward scapulothoracic की कौन-कौन सी movement हुई? Elevation, depression, protraction, retraction, right? And forward rotation and backward rotation. I hope this is clear to everyone. So during 180-degree movement, 60 degrees contributed by the scapula. So mechanism क्या है? Scapular rotation initiated by acromioclavicular joint, right? Then rotating forces are transmitted to the sternoclavicular joint. So what is happening here? Right? The movement is starting at the acromioclavicular joint. Clear? It moves upward. There is an upward rotation at here. And this provides a rotatory movement here. Means there is a posterior rotation of the sternoclavicular joint. Posterior rotation. पूरी की पूरी clavicle rotates upward. And this goes like this. So what is happening here? Acromioclavicular joint पर upward movement होती है, जिसकी वजह से sternoclavicular joint पे rotation होती है, posterior rotation. So posterior rotation होते ही this glenoid fossa goes upward. In fact, the inferior angle goes upward. Clear? And when this comes back, this is called downward rotation. Clear? Now let's move to the important one. Glenohumeral joint. Glenohumeral joint. A joint which is present between a scapula and your humerus, present between a scapula and your humerus. This is also called as shoulder joint. It is also called as shoulder joint. Now the articulating surfaces are, see the articulating surface here. First see the type of this joint. The joint is multi-axial, means all the movements are provided by this joint. Flexion, extension, abduction, adduction, circumduction, medial rotation, lateral rotation. So it is a multi-axial, means in all the axes, all the movements are happening, right? Now what is the type? Which type of synovial joint it is? It is a ball and socket joint. It is a ball and the socket joint. The ball is provided by a head of the humerus. It is one-third peripheral part is articulating with the glenoid fossa of the scapula, right? So the socket is provided by the glenoid fossa, pear-shaped glenoid cavity, and the ball is provided by the head of humerus. The articular surfaces are lined here by hyaline cartilage, right? The sternoclavicular and the acromioclavicular were lined by the fibrocartilage, but this joint is lined by the hyaline cartilage. Now see the capsules and the ligament, right? The capsule of the shoulder joint is thin and lax, right? Very much lax, right? Medially it attaches to the margins of the glenoid cavity, including the margins of labrum also. And laterally it attaches to the anatomical neck of humerus, except at 2 points. This is the anatomical neck of humerus, except at 2 points. What are those points? First, at the upper part of the intertubercular sulcus. Here it is deficient. And down below, it descends 1 centimeter downwards, right? And reaches to the medially, it reaches to the surgical neck of humerus. Clear? So this is about the fibrous capsule. Inside the fibrous capsule, the joint cavity is lined by synovial membrane. Next comes, right, now the shoulder joint capsule. As I have told you, it is thin and lax, right? So it is strengthened by the slips of tendons of rotator cuff. Now what are the muscles of rotator cuff? You people must be knowing that is subscapularis, supraspinatus, infraspinatus, and teres minor. Let's see the location. Subscapularis tendon lies anteriorly to the fibrous capsule. So anteriorly, the capsule is supported by the subscapularis tendon. Superiorly, it is supported by a supraspinatus tendon. It is strengthened by the supraspinatus tendon, and posteriorly by the infraspinatus, and below teres minor. But down below you can see that it is very much loose, right? Joint capsule here is very much loose, and it gets in abduction supported by the triceps muscle, by the long head of the triceps muscle, only in abduction. So inferiorly there is no strengthening of this capsule. Next come to the glenoid labrum. The glenoid labrum is fibrocartilaginous rim, right, which is triangular in cross section. It attaches to the margins of the glenoid cavity. Why it attaches here? To deepen the socket, so that because the mobility provided by the glenohumeral joint or by the shoulder shoulder joint is very much, बहुत ज़्यादा mobility provide होती है at the expense of its stability. So we need little things to stabilize it more. So we can so there is a glenoid labrum, a fibrocartilaginous rim, which is further deepening this fossa here, right? So the glenoid labrum deepens the fossa for better articulation of humeral head, right? Next, ligaments. What are the ligaments present? One is the glenohumeral ligament, transverse humeral ligament, Coraco humeral ligament. Yeah. So 3 major ligaments are glenohumeral ligament, transverse humeral ligament, and Coraco humeral ligament. If you see here, glenohumeral ligament 1, 2, 3, superior, middle, and inferior. These are thickening of anterior part of fibrous capsule. These 3 fibrous bands are actually derived from the thickening of the fibrous capsule, and you cannot see it from outside. you need to dissect the shoulder joint and the fibrous capsule, and then you will see it. Matlab, from inside the joint cavity, you are able to see these ligaments only, glenohumeral ligament, right? So you will all the glenohumeral ligament converge upwards and medially. From here, they're going medially to the superomedial margin of glenoid cavity. Superomedial margin of glenoid cavity, and laterally, there the superior glenohumeral ligament attaches to the upper part of the lesser tubercle. The middle one attaches to the lower part of the lesser tubercle. Clear? And the third, posterior one, okay, the inferior glenohumeral ligament, it attaches to the surgical neck of the humerus. To the surgical neck of the humerus. So these are the three ligaments which are providing the strength to the fibrous capsule. So, clear? Now next comes the transverse humeral ligament. The transverse humeral ligament is present actually here, right? It connects the two lips of upper part of intertubercular sulcus, and it acts actually as a retinoculum to prevent the displacement of the long tendon of the biceps. This is the long tendon of the biceps, right? So to prevent the displacement of the long tendon of the biceps. So it is present here, transverse humeral ligament. Now next come is Coraco humeral ligament. This is Coraco humeral ligament. The Coraco humeral ligament is thick band in the upper part of the fibrous capsule. This is the upper part of the fibrous capsule, and it is present as a thick band here. Clear? Attaches with a thick band here in the upper part of the fibrous capsule, and it extends from the lateral border of the coracoid process. This is coracoid process. Lateral border of the coracoid process to the anatomical neck of the humerus. This is the anatomical neck of the humerus. Clear? Between the greater and the lesser tubercle. The ligament resists the lateral rotation and the adduction. So it is of also very important ligament, Coraco humeral ligament. Now, the joint stability. How this joint is stable, because it is providing so much of the mobility, we need the stability points. So what are the things which are providing the stability to this joint, right? The stability is maintained by the, again, rotator cuff muscles, right? So superiorly, if we see, right, there is a fibrous capsule, and above to it there is a supraspinatus muscle, which prevents the downward displacement of the humerus. Interiorly, subscapularis. Posteriorly, there is infraspinatus and teres minor. And down below, in abduction, right, it is prevented by the long head of the triceps muscle, right? So this is the rotator cuff muscles which are providing strengthening this joint, right? And down below in abduction, the triceps is also supporting with teres major. Okay. The third is glenoid labrum. The labrum is deepening the fossa, right? And the upward displacement of the humeral head is prevented by the long tendon of the biceps and by the Coraco acromial arch, right? By the Coraco acromial arch. This arch is formed by the coracoid process, acromion process, and there is a ligament in between, right? So this acromial arch prevents the upward displacement of the upper of the humeral head. So by seeing the stability, it is very much clear that inferiorly there is not so much support, right? There is no proper support. Only in abduction the triceps is coming here for the support of this fibrous capsule or for this joint. Otherwise there is no support inferiorly. So likely there is more common dislocation inferiorly only. Let's see the relations of the shoulder joint. You people know the relation of the shoulder joint. It is very easy, right? What are above? Sorry. It is very easy. Above to the joint. You can see here, right? This is the glenoid fossa, right? Labrum, fibrous capsule, and above to it, this is above, there is supraspinatus muscle, right? Above to the supraspinatus muscle, there is a bursa which is known as subacromial bursa, and above to it, there is a coracoacromial arch. Coracoacromial arch, which is supporting from above. Downwards to its relation. The first thing is axillary nerve. Second, posterior circumflex humeral artery, right? Posterior circumflex humeral artery, right? And downwards there is a long head of triceps. Long head of triceps inferiorly. Let's see in front there is a subscapularis muscle. There is a subscapularis muscle and even the coracobrachialis muscle. Posterior to the joint, there is infraspinatus and teres minor. And to all of your knowledge, the shoulder joint is covered in front, behind, and laterally by a muscle which is supplied by an axillary nerve that is known as deltoid muscle, right? So in front, behind, and laterally, the whole joint is covered by a muscle known as deltoid muscle. I hope the relations are clear to everyone. Next, the bursa. There are three main bursas, that is subscapular bursa, infraspinatus bursa, and the subacromial bursa. Clear? First, see the subacromial bursa. It lies just above to the supraspinatus. Clear? The subscapular bursa lies behind to the subscapularis muscle, and this may get its communication with the joint cavity also. Clear? And there is an infraspinatus bursa which lies just below the infraspinatus muscle, and sometimes also 10% there are chances that this may also get connected with the joint cavity, right? Now, what are the blood supply of this joint? Its blood supply from the brachial artery branches, that is anterior circumflex humeral vessels, posterior circumflex humeral vessels, right? Suprascapular vessels, and from subscapular vessels. Clear? Nerve supply, which is very important, right? It gets its nerve supply from axillary nerve, from suprascapular nerve, right? And from lateral pectoral. One from axillary nerve, one from suprascapular nerve, and another from lateral pectoral nerve. I hope you remember the lateral pectoral nerve. The lateral pectoral nerve is arising from the lateral root, and it also supplies the pectoralis major. Now let's see the movement at the shoulder joint. What are the movements at the shoulder joint which we can perform? Flexion, extension, flexion, extension, abduction, adduction, abduction, and adduction. And with the flexion, extension, abduction, adduction, there is circumduction. Right? What else we can perform is medial rotation and lateral rotation. Medial rotation and lateral rotation. So let's see first the flexion and extension. In the flexion and extension, right, takes place at the right angle to the plane of the body of scapula, around a transverse axis, right? The angle is reduced in flexion and increases in extension. Clear? Now, in abduction, adduction takes place parallel to the plane of the body of scapula, around an anterior-posterior axis. The circumduction is happening in all the axes. Medial and the lateral rotation. It is occurring in vertical axis, right? It is occurring in vertical axis. The axis extends from the center of the humeral head to the center of capicula. Clear? Now, what are the muscles which are produced these movements? For a quick brief, main muscles I'm going to elaborate, right? The flexion is produced by the pectoralis major, clavicular part, and by the deltoid interior fibers. Extension by deltoid posterior fibers, and latissimus dorsi. Adduction by the pectoralis major, sternocostal part, and latissimus dorsi. For the abduction, majorly till 90 degrees, the deltoid and supraspinatus muscles are involved. I will, in the next slide, I will discuss more in detail about the abduction. The medial rotation is mainly performed by the subscapularis muscle. Accessory muscles are there, pectoralis major and latissimus dorsi. And the lateral rotation is mainly, prime mover is deltoid posterior fibers, right? And synergists are infraspinatus and the teres minor. So let's see the abduction. Abduction. Let me perform abduction for you people. All right, abduction. 0 to 15 degree. 0 to 15 degree, mainly contributed by the gravity. I say that it is by supraspinatus, but if I say that the supraspinatus is paralyzed, then can we perform 0 to 15 degree? Means we cannot initiate abduction. No, we can appreciate, we can perform, right? So what we do, if there is a supraspinatus muscle paralyzed, we ask the patient to bend down, right? And once we bend down to an abnormal side, there is an increase, right? The hand reaches to the 15 degree. And from 15 degree, the deltoid pulls up to the 90 degree, right? Above to the 90 degree, we need another muscles, right? From 0 to 15 supraspinatus, 15 to 90 is deltoid, and for overhead abduction, we need trapezius and levator scapula. Mainly, the prime mover is trapezius. Clear? So let's see first. Here you can see, right? It is a neutral position, 0 to 15, 15 to 90, and from 90 to 120 to 120 to 180 degrees, right? How we are doing the abduction. This is the whole mechanism of abduction from 0 to 180 degrees, right? For the overhead abduction, please listen carefully. Not only glenohumeral joint is involved, the whole shoulder complex involved, right? Whole shoulder complex means the sternoclavicular joint, acromioclavicular joint, scapulothoracic joint, and glenohumeral joint. All the 4 joints work with contribution to perform the abduction. Clear? So beginning with 0 to 15 degrees, which is by the gravity and supraspinatus. Listen properly. This is performed by the glenohumeral joint, right? All right. From 15 to 90 degrees, right? From 15 to 90 degrees, the deltoid is performing its work, right? And once the hand reaches to the 60 degrees, once the hand reaches to the 60 degree, means from 15 to 60 degrees, right? The humerus rotates medially. The humerus rotates medially. And after that, to increase the range of abduction, the humerus moves in the plane of body of scapula. First, it was from 15 to 60 degrees. It was rotating medially. Once it reaches to the 60 degree, to increase the range of abduction, the humerus now moves in a plane of body of scapula. Clear? Now, only after initial 30 degrees, as I have told you, not only humerus is working in abduction, the scapula also take participation. So once the humerus completes its first 30 degrees, the scapula contributes. Pataxis scapula comes in role, right? And it says that the humerus moves 10 degree, I will move 5 degrees. 1:2 ratio कहते हैं हम लोग. वो क्यों कहते हैं? The initial 30 degrees is provided by the humerus alone, right? And after 30 degrees of abduction, the scapula, the scapulothoracic joint, acromioclavicular joint, sternoclavicular joint comes in role, right? And on each 30 degrees movement of humerus, the scapula moves 5 degrees. It contributes 5 degrees, right? So please, I'm enumerating it again. From 0 to 15 degrees at humerus is moving, right? And the supraspinatus muscle is involved. Majorly, it is gravity. From 15 to 90 degrees, deltoid takes its role and performs the abduction. Beyond 30 degrees, 0 to 30 degrees के बाद, the scapula comes in roll. And once the humerus moves 30 degrees, means from 30 degrees to 40 degrees, if humerus moves, the further 5 degrees will be added by the scapular movement, right? So it reaches to the 45 degrees, right? I hope you people are understanding this. The initial 60-degree rotation is in medial position, and beyond to it, the humerus and the scapula moves in a plane of body of scapula. Remember, acromioclavicular joint was also moving in the plane of body of scapula only, in the plane of scapula. So beyond the 60 degrees, it moves in a plane of body of scapula. Now it reaches to the 90 degrees. It reaches to the 90 degrees. So from 90 degree, it has to go above 120 degrees. And from 120 to 180 degrees. So from 90 to 120, what happens? From 90 to 120, the humerus rotates laterally. First, it was rotating in medially, then in the plane of body of scapula, and from 90, it has to go above. The range of abduction has to increase, which will increase when the humerus will rotate laterally. And this lateral rotation of the humerus will occur due to the contraction of infraspinatus and the teres minor muscle. And this humerus movement is associated with scapular movements also, right? Once the hand reaches to the 120 degrees, right, then it goes towards the 180 degrees. Now here, what happens from 120 to 180 degrees, the 30 degrees are added just by the scapular rotation only, right? So what happens? The upward rotation of acromioclavicular joint occurs, followed by axial rotation of sternoclavicular joint. The clavicle moves to the posterior rotation, takes the posterior rotation, right? And this only movement adds 30 degrees to the further elevation. And now after this reaching to the 180 degrees, and after this last 30 degrees elevation, the glenoid cavity faces upwards. And this movement happens by the contraction of the upper and the lower fibers of trapezius. Serratus anterior, right? And we need to check कि कहीं इस overhead abduction में dislocation नहीं हो जाए. And this dislocation is prevented by the middle fibers of the trapezius. Means the middle fibers of the trapezius stabilizes the scapula during the abduction. I hope the mechanism of abduction is clear to all of you. I tried my best. Right? Now let's see the injuries. First, I'll come to the shoulder dislocation, which is more prominent. The sports person in your batch also must be knowing 1 or 2 cases of shoulder dislocation. So as I have told you that due to providing the mobility, the stability is very less. And there are a lot of cases you people will see of shoulder dislocation, right? So, and in that also the antero-inferior dislocation is more common. Antero-inferior dislocation, not only anterior, not only inferior. The antero-inferior dislocation is more common, right? Than the posterior dislocation. Clear? Now, some cases you will hear that there is a lot of dislocation. One person of having the right side dislocation is again and again coming with the dislocation only. Why dislocation? Again and again, why dislocation is happening? Because due to frequent dislocation, one condition arises that is known as Bankard's lesion, in which the head damages the labrum, glenoid labrum. The anterior part of the labrum gets damaged due to the frequent dislocation, and this will also causes the frequent dislocations also. So this can be a cause, right? This can be a problem, right? So this lesion, tearing of the anterior part of the glenoid labrum, is known as Bankard's lesion, right? This is about the dislocation. Frozen shoulder. In frozen shoulder, what happens? The capsule, the joint capsule gets thick and inflamed, and whenever the person performs the movement at the shoulder joint, it will give a symptom of extreme excruciated pain at the shoulder joint while performing the flexor extension or abduction adduction movement, right? So in which what happened? The capsule gets inflamed. There can be rotator cuff injuries, right? Where the supraspinatus can get impinged under the acromion process, right? There can be inflammation of the or damage to the supraspinatus due to the overuse tendinitis. Overuse means frequent abduction and adduction. Frequent abduction may cause damage to the supraspinatus. So as I've told you that the rotator cuff is more important for the stabilizing the joint because it is supporting and strengthening the joint. So the joint will become weak, right? So these are the clinical applied part of the glenohumeral joint. Thank you very much. I hope you liked the session, and I'm extremely sorry for the network glitches which happened in between. And I hope that you liked the session and it was easy for you to understand. Thank you very much. Deepika ma'am?
Yes, Dr. Nishat.
Deepika ma'am?
Yes, can we end the session?
Yes, ma'am. Yes,
yeah, okay, thank you.
Thank you very much, ma'am.